Good afternoon, everyone, and welcome to today's webinar on fall-related traumatic brain injuries among older adults, offered by the National Association of State Head Injury Administrators. I'm Susan Vaughn, Nasha's Director of Public Policy and a member of the Training and Education Committee, which is chaired by Carrie Bennett, who is also the Acquired Brain Injury Program Director and the Nebraska Vocational Rehabilitation Program. Behind the scenes, administering the webinar is Maria Crowley, Coordinator of the Alabama State Head Injury Program, located in the Department of Rehabilitation Services, and also a member of the committee. And both these individuals are also a member of the Board of Directors. The committee plans and carries out these webinars in keeping with NASHA's mission to assist state government in promoting partnerships and building systems to meet the needs of individuals with brain injuries and their families. On behalf of NASHA, the Board of Directors, and the committee, thank you for joining us. Before we begin, I have just a few housekeeping details. A GoToWebinar user guide is available for download from the NASHA website noted here. This is a great resource for making the most of your webinar experience. An online GoToWebinar help button should also be visible at the top of your attendee control panel. For technical assistance, you may also call either the numbers listed here, and you may want to write these numbers down. To control background noise, all attendees' microphones will be muted during the presentation. However, you may submit questions for the presenters at any time by typing and submitting them in the question text box on your GoToWebinar toolbar. Any questions that are not answered during today's webinar will be answered later by email. Please watch for an evaluation of today's presentation at the end of the webinar. It will pop up on the screen when the webinar is closed. We welcome and appreciate your feedback. Our objectives today are to explain the impact of fall-related TBI injuries among older Americans, explain strategies to address older adult falls and the role of CDC to reduce falls among older adults, and to present information on states' activities to address older adults with traumatic brain injury. Today, we have a record number of nearly 700 people who registered across the country. To know a little more of your work in the field of older adults and traumatic brain injury, we have two poll questions. The first question is, do you or your agency use CDC's Injury Center's prevention materials aimed at reducing fall-related injuries among older adults? And you can answer yes, no, not now, but have in the past, or do not know. And I'll give you a few seconds to respond. So if we look at the results here, it looks like 36% of you responded that you do use the materials, and that 33% of you do not know. So this is great to know. Now we'll have a second question. Are you or your agency engaged in activities to address older adults with TBI and long-term service settings? Yes, no, no, but we are beginning to, or do not know. We will give you a couple seconds to respond. In our results, it looks like 40% answered yes, 31% answered no, and 17% do not know, but 12% of you are saying no, but we're beginning to. Now I'm pleased to introduce our speakers. Our first speaker is Dr. Grant Baldwin, who is the Director of the Division of Unintentional Injury Prevention at the National Center for Injury Prevention and Control. He has served in this capacity since September 2008. Dr. Baldwin received his PhD in Health Behavior and Health Education at the University of Michigan School of Public Health in 2003. He also received an MPH in Behavioral Sciences and Health Education from the Rollins School of Public Health at Emory University in 1996. Dr. Baldwin is an adjunct assistant professor in the Department of Behavioral Sciences and Health Education for the Rollins School of Public Health at Emory University. Our next speaker will be Dr. Michelle McKelvey, who is an associate professor at the University of Nebraska at Kearney. She has taught courses and conducted research in the areas of traumatic brain injury, augmentative and alternative communication, aphasia, and motor speech disorders for the past 9 years. Dr. McKelvey has over 18 years' experience in the assessment and treatment of individuals with acquired communication disorders. Our final speaker will be Gabrielle Lawrence Soto, who is the program coordinator for the federal TBI state grant awarded to the Massachusetts Rehabilitation Commission, which is using grant funds to focus on older adults with traumatic brain injury. Gabriella comes to the state with extensive experience working with various populations such as older adults, individuals with brain injury, and persons at risk for low income. She previously worked in various community programs, including as a case manager for a private case management company which contracted with the Massachusetts State Head Injury Program at the Massachusetts Rehabilitation Commission. She has a BA from Hamilton College and is working toward a master in program and project management from Brandeis University. Now I call on Dr. Baldwin to start the webinar.
Thank you very much, and good afternoon or good morning, depending upon where you are in the world. The U.S. is entering a new era. We have more people over the age of 65 than ever before. As you know, 10,000 people age into the senior category every day. While this gives our nation an unprecedented gift to learn and benefit from the wealth of their knowledge and experience, it also poses a challenge for meeting the needs of these older adults and making sure that they can live healthy, safe, and independent. For more than 20 years, the CDC Injury Center has been a leader in reducing the burden of injuries across the lifespan. Prevention is our calling. We know that traumatic brain injuries and deaths caused by falls can be prevented. This is the aim we're all working towards. After highlighting the burden of falls and TBI, I'll talk about what CDC is doing to make a difference and scale up our prevention efforts for the greatest population-level impact. Here's what we know. Each year, millions of Americans aged 65 and older fall, and about 25,000 older adults die from them. That's one American every 20 minutes. As striking, about half of these fatal falls are caused by a TBI. Falls are the leading cause of injury death among older adults, and non-fatal falls affect many older adults too. Falls also result in significant medical costs and are among the 20 most costly medical conditions. We spend about $34 billion a year on direct medical costs alone. Let me put a finer point on this. From 2006 to 2010, falls were the leading cause of TBI, accounting for 40% of all TBIs in the U.S. that resulted in an ED visit, hospitalization, or death. Falls disproportionately affect older Americans. More than 80% of TBIs in adults over the age of 65 are caused by falls. Studies have identified numerous fall risk factors. Those that are modifiable are often classified as biological, environmental, or behavioral, shown here on the slide. The strongest risk factors are leg weakness, problems with mobility and balance, and taking psychoactive medications like tranquilizers, sedatives, and antidepressants. The more risk factors a person has, the greater their chances of falling. One study found that the proportion of people who fell increased rapidly from 27% for those with one risk factor to 32% to those for those with 2 risk factors, to 60% with 3, and to 78% for those with 4 or more risk factors. Even among community-dwelling adults over the age of 75 without risk factors, 10% fall during any given year. Among people who fall, less than half talk to their healthcare provider about it. And that's just part of the story. Falls and TBI not only affect a person's overall health, but also their quality of life. Seniors may restrict their activities because of fear of falling or a fall that resulted in a TBI. In turn, this can lead to reduced mobility, fewer social interactions with friends and family, and decreased physical fitness. So the fear of a fall or a subsequent fall after sustaining a TBI spirals an older adult's overall health downward. A single injury event manifests as a chronic condition. That is why CDC also focuses on improving outcomes and promoting healthy lifestyles for persons living with TBI. At CDC, we saw a significant opportunity and an unfilled need by bridging these 2 realities. First, the small fraction of patients who talk to their physician about their fall risk, and second, several important modifiable risk factors for falls can be addressed by a healthcare provider. Falls are a complex issue that requires a multifaceted approach. We recognize the meaningful and unique contributions that you and other partner organizations like ACL, focused on community programs, the National Council on Aging, CMS, and others make to address falls. For CDC, it's important that our efforts are strategic, complementary, and fill existing gaps in the field. To this end, our updated overall strategy is to make fall prevention, screening, assessment, treatment, and referral a routine part of clinical care. Included in this is supporting the linkage to effective community-based programs. What will this do? Well, we know that clinical assessment by a healthcare provider combined with individualized treatment of identified risk factors reduces the rate of falls by almost a quarter. Strengthening the linkage between public health and clinical medicine is a CDC priority. Specifically, it's about improving prevention in healthcare. CDC Director Dr. Tom Frieden often highlights 5 key areas where we could make a big difference, including reducing practice variability, engaging the entire healthcare team, building accountability through health IT support, remaining patient-centered, and supporting innovation and evaluation. Fortunately, CDC's work in older adult fall prevention aims to do all of these. Our work can help simplify, harmonize, standardize, and automate systems and evidence-based practice protocols for improved outcomes. When integrated into health IT, this will enable rigorous utilization of clinical guidelines, reduce barriers to access and follow-up, provide clinical decision support tools for clinicians and patients, and foster public-private insurance mechanisms to incentivize best practice. If we train and provide physicians with the necessary tools, they can be a significant, trusted, and frontline resource in our attempt to reduce falls and TBI. While physicians report being aware that their patients are at a risk for falls, many don't know how to assess this risk. We created the STEADY initiative, or Stopping Elderly Accidents, Deaths, and Injuries, for primary care providers who see older adults in their practice. STEADY uses established clinical guidelines and scientifically tested interventions to help providers address their patients' fall risk, identify modifiable risk factors, and provide effective interventions. It's integrated and team-driven. STEADY tools include basic information about falls, case studies, gait and balance tests, and educational handouts about fall prevention for patients and their families. Well, with the limited amount of time a provider typically has with each patient, one of the earliest lessons learned with STEADY implementation was, could it be streamlined further? As a result, we created STEADY Step 1. STEADY Step 1 hones in on 3 screening questions and 2 clinical interventions. It can be summarized as ask, review, and recommend. Ask patients if they've fallen in the past year, feel unsteady when walking, or worry about falling. Review medications and stop, switch, or reduce the dose of prescriptions that increase falls risk. And recommend vitamin D supplements of at least 800 international units per day with calcium. These questions should be asked at each encounter a primary provider has with an older adult. Study Step 1 serves as an easy triage tool for more rigorous assessment outlined in the full study algorithm. It also ensures 2 evidence-based clinical interventions, medication review and vitamin D supplementation, are a default in patient care. We recently worked with Medscape to create a video showcasing the utility of this approach. Currently, 50% of older adults are vitamin D deficient. Considerable research has measured the effect of vitamin D on fall prevention. That said, there is considerable heterogeneity in individual studies. We based our recommendations on the published meta-analysis and the recommendations from the American Geriatric Society and the U.S. Preventive Services Task Force. The meta-analysis suggests the effectiveness of vitamin D ranges between 13 and 22%. CDC suggests physicians advise all older adults to take at least 800 international units of vitamin D daily, co-administered with calcium to reduce falls and optimize bone health. Many seniors use medications such as analgesics, benzodiazepines, antidepressants, and sedative hypnotics that increase the risk of falling. Psychoactive medications in particular are an independent predictor of falls. These medications tend to be sedating, alter your senses, and impair balance and gait. Potentially inappropriate medication use occurs in 21% of older adults. A key strategy is to reduce the dose of any indicated medications that may contribute to fall risk and to taper and stop any medications that are no longer needed. Part of this is confirming the dosage is in agreement with the recommended geriatric dose or considering whether an alternative medication may be warranted, one with less fall risk. Optimizing medication usage can reduce falls by up to 66%. 2 ways to scale up efforts and promote consistent implementation of STEADY is to better educate providers about its utility and incorporate STEADY into electronic health record systems. For education and uptake, we originally used an academic detailing model. However, we quickly realized that this was neither efficient nor scalable. As a result, we shifted focus and are working on several online continuing education courses that award continuing education credits to providers. The first of these trainings was released this past July in conjunction with the White House Conference on Aging and focuses on our STEADY tool. Subsequent trainings will be targeted towards primary care providers and pharmacists. We are pleased to offer CE credits for several medical and public health professions. EHR systems are widely used by providers to streamline patient care in the clinical environment. Specifically, they use EHRs for clinical decision support, maintaining a patient's medical records, and of course for billing. EHR prompts can streamline the screening and management process. We're working with a couple of EHR vendors as well as the Office of the National Coordinator to make this possible. And we expect the first module available via Epic to be released at the end of this year. We developed this guide to help communities identify appropriate evidence-based fall prevention programs that can be implemented in their community. It also describes the resources needed to implement and sustain these evidence-based fall prevention programs. The main purpose of this guide are to, among other things, promote an integrated collaborative approach to fall prevention, provide guidelines for selecting an appropriate fall prevention program, suggest approaches to improving program implementation, provide methods for evaluating programs, and finally to provide resources and strategies to increase sustainability. All of these are essential for standing up and maintaining an effective program. The user guide, shown here, and the compendium of known effective interventions that was released with it are available on our webpage. So you're probably wondering, what difference will this make? Well, for every 5,000 healthcare providers who adopt STEADY over a 5-year period, as many as 6 million more patients could be screened, 1 million more falls could be prevented, and 3.5 billion more in direct medical costs could be saved. And so we need your help to fully realize these ambitions. Let me shift for a moment to talk about TBI surveillance. Estimates of the annual number of TBIs are collected from 3 different sources: TBI-related hospitalizations, TBI-related ED visits, and death certificate data with TBI listed as the cause of death. We know that this is an underestimate of TBI as it misses TBIs that go untreated and TBIs that are treated in outpatient settings. Beyond seeking to improve overall TBI estimates, we are seeking to improve our surveillance in the following two ways. One, providing true national estimates of TBI-related disability for the first time ever. Previous estimates are outdated and based on extrapolations from single states. And two, producing state-specific estimates for a larger number of states. This will help state-level decision makers to understand the unique burden of TBI in their state. More broadly, CDC was charged by the Institute of Medicine and encouraged by the administration and members of Congress to stand up a national surveillance system that will assess the burden of youth sports and recreation-related concussions. As our plans for the system developed, we realized the same methods used to capture that information could give us new and important information about TBIs from all causes, including those among older adults caused by a fall. If we do these things, we'll not only have a better sense of the problem because of improved data, we'll also know if our prevention efforts are making a difference. So let me close here. Thank you again for all that you're doing to prevent TBIs. We're trying to do our part at CDC and appreciate our collaborations across the field. Together, we can have the impact that we all want to see. Much of what I've just outlined about the CDC approach can be found on the CDC webpage at www.cdc.gov/injury. I look forward to the discussion that follows. Thank you very much.
Thank you, Dr. Baldwin. Again, if you have any questions of his presentation, submit them in the question box. Our next speaker is Dr. Michelle McKelvey.
Hello, everyone. Okay, here we go. We're going to talk a little bit today on the brain injury screening that we've been doing here in rural Nebraska through the Area Agency on Aging. Given the statistics that were just presented, the risk of fall in our elderly population and therefore the risk of TBI is higher than the general population. So here in Nebraska, we wanted to investigate or target a population that would be high risk and then be able to screen them to make sure that services that were provided to them were targeting their injury or resulted in better overall care for them by identifying that they had a potential traumatic brain injury. So the purpose of this research project that we conducted was twofold. One, we wanted to train service coordinators at the Area Agency on Aging about brain injury and also train those service coordinators to use a screening tool to identify their patients that may have a brain injury. Then we sought to seek some feedback from those service coordinators after we trained them and they'd gone out to use the tool to see how they felt about the tool. Did they find that it was useful with their client population? And then also we wanted to look at the data about the number of clients that they screened and then how many of those screenings resulted in a positive screen in a patient that may or may not have a brain injury. So the first thing that we ask these individuals to do, we presented them with some education about brain injury. So we provided a PowerPoint that talked about the symptoms of brain injury. We gave them a pre-post quiz before that education to find out, to get a baseline knowledge, a baseline measure of their knowledge of head injury, then gave them the training about what brain injury is, some symptoms to identify, and then the post quiz at the end of that. After that particular training, we asked them to then participate in screening individuals for brain injury. So we used for that the Ohio State University Traumatic Brain Injury ID tool. We trained the service coordinators to administer that screening tool as part of their intake evaluations for any new patients that they were going to be seeing, and also to screen the individuals that were already on their caseload. We did that for about 3 months. We asked them to go out and take some data on that and turn that into us, and then we compiled that data and looked at how many individuals they screened and the number of positive screens that were identified. After that 4-month period or 3 month of screening, we went back out to them and then did a follow-up survey or a follow-up presentation and asked them their opinion on the screening tool and how well they thought it worked in terms of identifying those individuals, the ease of administration, and also anything else that they wanted to talk to us about in regarding the use of the tool. We also at that time presented them with information about where they could seek services for individuals who had a positive brain injury screen, specifically services for speech-language pathologists. So we identified individuals within their area that they could seek out for a formal evaluation of any client that had a positive screen, and then provide additional services to that individual in their home. One of the things that I'm going to talk just a little bit about the pre-post survey, was a 25-question true-false survey, and the individuals completed that and they did fairly well after the training, which was good news. So it showed us that our specific information that we gave them regarding brain injury and their knowledge of that had increased. The OSU TBID screening tool that they used consisted of 6 questions that they went out and asked their clients. And what we liked about the tool is that it probed for potential brain injuries in a way that didn't just directly ask the client, well, have you ever had a brain injury? Because if you ask them that, of course they're going to say no, because they're thinking of things like major trauma to the head, and not necessarily the things that we know cause mild head injuries like falls. So, for example, one of the questions that's asked on the OSU ID is, have you ever injured your neck or head in a car accident or some other form of moving vehicle? It again gets at that information that we want from the patient without directly asking them, but makes them think about other injuries that they've had to their head and neck. The results of our training ended up that the service coordinators felt that they did have an increase in their knowledge about TBI, about traumatic brain injury, and also the recovery process, the typical soliloquy of a brain injured patient, and also more information about disorders of consciousness. On average, they increased their score of accuracy. Out of 11 questions, they averaged 6.42 questions they got more right the second time at the post-injury, which was great. We wanted to see that. And then when we went back and did that follow-up about asking them about ease of administration of the screening tool, how their patients reacted to it, would they consider making it a part of their regular intake paperwork, many of them stated that it would just be another form that would easily slip into their admission for new clients. They also indicated that once you'd gone over it a couple times, it had become rather user-friendly. And they gave us some specific things about the form that they would change to make it more user-friendly. And the developers of the tool, John Corrigan, had already actually made those changes in the form. So it was very easy to give that back to them in a more user-friendly way. The one thing that they did also talk about in their experience with screening their individuals is that they, one, needed more information about services that they wanted to provide or where they could get services for their clients who had positive screens. And a lot of them talked about the screening process allowing them to get to know their patients better. And the patients described often events that occurred in their life that were not part of their medical record. For example, injuries that had happened in their 20s that were related to either a car accident or frequently military injuries that were not part of their medical records. It allowed the patients to describe those things and for the service providers to then have an idea about additional brain injuries that this person occurred. Another frequent thing that was identified were incidences of abuse that were not part of the medical record or recorded. Several of the participants that were screened indicated that they had been battered and that those resulted in several losses of consciousness. So ultimately what we came out of with that, the AAA, the clients that were actually screened by the case managers, we had 99 individuals that we did this on, or 99 individuals that were screened through one agency. Over half of them reported some kind of incident that would be considered a possible brain injury. However, as the questions progressed and they talked to the individuals about did they experience any symptoms from those brain injuries, many of them reported that they experienced some dazed or memory gaps, but the majority of them did not. So we had several individuals that with positive screens, after we determined and looked back, there were 28 of those individuals that had positive screens, and about 14%, or 14 of those 28 individuals did not experience a loss of consciousness, but experienced memory gaps or reported being dazed and confused. You'll see there to the right on the screen is how we ask them to report consciousness. If they remember being unconscious for under 30 minutes, for 30 minutes to 24 hours, or greater than 24 hours. A lot of times those individuals said they did not remember experiencing any periods of unconsciousness, but they reported symptoms, which is kind of what we're seeing in the literature today. You don't have to experience unconsciousness in order to have symptoms from brain injury, which was very positive, at least for us. This was the pilot data for a larger screen, so we asked, given the results of this pilot study, we wanted to go out and screen and train all of the service coordinators in the state of Nebraska, and we're a pretty big state. So we have a lot of geographic areas, but we're also a very rural state. So it became important to, once these people were identified, to then also identify places where they could receive services. So we've continued this into other agencies in the area. My slide's stuck. Here we go. So in that first, we just did our local Kearney area, and we had 99 participants that were screened by our area service coordinators. We've since then expanded to 2 other area agencies on aging. And we have a total of just over 400 participants that have been screened. You can see in North Platte, the service coordinators there have screened 183 participants. 76 participants were deemed positive screens. That's over 42% of those individuals whose initial diagnosis was not traumatic brain injury. It was something else. In Scottsbluff, which is another rural area in Nebraska, we've screened over 231 participants. 38 of those participants had positive screens, 16% of those individuals, and 6 participants with more than 2 injuries. I forgot to mention up in the North Platte area, over 21 participants identified that they had more than one brain injury. So it is a rising problem with our elderly folks, and these were, almost all of these individuals did not have traumatic brain injury as their primary diagnosis. They were being seen as something else, nor was a traumatic brain injury part of their medical record. Those are, that's where we are so far in the project. We are going to continue to look at screening. We are going to continue to train and screen through the Area Agency on Aging, helping those individual counselors identify their participants that have a potential brain injury, and then pointing them to services that they can use and identify for those individuals. And lastly, I'd like to thank John Corrigan and Jennifer Borello. Those are the developmenters. They developed the Ohio State University Traumatic Brain Injury Screening Tool, and were very generous in allowing us to use it in this. And then also the HRSA grant. This research was funded through a HRSA grant through the Brain Injury Association in Nebraska, and also through vocational rehabilitation. Thank you, and I'll be happy to answer questions at the end.
Thank you, Dr. McKelvey. Both Dr. McKelvey and Dr. Baldwin will remain on the call to answer any questions as time allows. So you can continue to pose your questions in the question box. However, you may want to look at some of the previous questions. We're noticing that several people are asking comments with regard to whether the webinars will be posted and if certificates will be available, and all that's being answered on that question panel. So if you want, take a look at to see what's been posed, and maybe your question's already been answered. If not, we'll be happy to take them. With that, we will have our final speaker, Gabrielle Lawrence Soto from Massachusetts. Thank you.
Good morning, everyone. Today I'd like to share with you some of the work that we're doing in Massachusetts. I'm currently the program coordinator for the HRSA Elder Grant called Improving the Massachusetts System of Care for Elders Sustaining a TBI. And just to give you a little background as to where we are in Massachusetts in terms of incidences, there was an epidemiology study conducted by a neurologist that worked for the Mass Rehab Commission and partnered with the Department of Public Health, which was published recently. So if anybody's interested in looking at that, you can find it in the mass.gov website. It's a very extensive study on acquired brain injury in Massachusetts. And the data that I have put on this slide is just giving you an overview of the incidences. We have over 67,047 incidences of TBI on average. We're expecting these numbers to continue to grow. As you can see, there are a lot of folks that experience hospital stays and go to the emergency room. So this grant was written in response to that. Other points that I'd like to highlight from the epidemiology report is that the highest rate of hospital stays were among residents that were 70 years and older, which was 4 times the rate of the overall population. And I feel like this is data that kind of follows closely in line with the trends that we're seeing nationally. The vast majority of the TBIs related to hospital stays were associated with unintentional falls. And then we found that residents in the Metro West and the Northeast region of Massachusetts were experiencing the highest numbers of hospital stays. That area right now for our grant covers about 83 towns out of 300, over a little over 300 towns in Massachusetts. So it's a big chunk. There is an increasing trend to continue as baby boomer generation continues to age and experience longer life expectancy. And then in comparison, we noticed that we only had 4.3% of eligible consumers were individuals that sustained a TBI after the age of 59. We're closely tracking the consumers that are receiving services at the State Head Injury Program, and we're looking to increase the number of elders that we serve. The need for the for those with TBI who are aging may not be the same as those who are older and sustain a TBI later in life. So part of the goal of the grant is to maximize the existing resources in both the TBI and the elder service delivery system. The Mass Rehab has the State Head Injury Program, which serves all consumers with traumatic brain injury. And then we have the Elder Care System, which is made up of the ADRCs, the Aging and Disability Resource Consortia, which are made up of the aging agencies, the ASAPs, and the independent living centers. So we wanted to tap into that existing structure and enhance the no wrong door. So this is a model that provides simplified, streamlined, consumer-directed access to coordination of services. You could call, through this grant, you can call the Mass Rehab Commission, call the Brain Injury Association, call the Aging Agency or the Independent Living Center, and all of them, through this grant working together, should be able to point the survivor or the family to brain injury services. We received this grant this July of 2014. It's a partnership between the State Head Injury Program, the Brain Injury Association, the Community Living Division of the Executive Office of Elder Affairs, and 3 ADRCs. That's the ADRC of Metro West, the ADRC of the Greater North Shore, and Merrimack Valley ADRC. Together, this is 6 agencies on aging and 3 independent living centers. When we started working together, we were about 6 months behind in schedules. The hiring process for the state is a little slow, so I came in around December, and we focused a lot of our early time identifying what data do we need to measure our success, and what challenges can we identify early on so that we can problem solve them along the way. And some of the challenges that came up were around schedules, breaking this grant into phases, and then learning about each other's databases. We're talking about 4 different databases between the Mass Rehab Commission, the aging agencies, and living centers, and the Brain Injury Association. When looking closely at the data elements for the aging agencies and the independent living centers, we identified that they are already collecting some data on traumatic brain injury. The element comes up as a head trauma or TBI cognitive. So those are the 2 elements that we'll continue to look at every 6 months and just see if we're noticing an increase due to awareness, and just see if there's any other patterns that we can capture along the way. We also want to track referrals exchanges, figure out if there's already a system for analyzing where the referrals are coming from, what kinds of referrals are being asked by consumers. And also, we've developed questionnaires. We want to know more about how our trainees are retaining the knowledge that they're gaining and how they're applying it. We also want to survey the consumers to see if they're satisfied with the services that they're getting in the community. And also we want to track the unmet needs. What are we seeing or not seeing enough of? And how can we advocate for those services later down the line? Are the barriers insurance, income, transportation, not enough day programs, things like that? So the grant is a systems change grant, and we've broken it up where we've added some structures. The first one that I want to talk about is the education and training to catch the unidentified elders with TBIs that are already being served in the elder service system. So we're doing a lot of cross-training with the independent living centers and the area aging agencies to identify consumers with brain injury and to give them strategies on how to work with these consumers and their families. And one tool that we're using to do this is the health screening tool, which I will go into more detail down the line. In addition to training the aging agencies on traumatic brain injury, we're also doing the reverse, where the Mass Rehab Commission staff and the brain injury staff are being trained on elder issues. and services that are available in the community. Just kind of strengthen the conversation and partnership between the three entities. The next step was increasing public awareness. So we are doing a lot of outreach activities, especially to the community-based multicultural organizations, where we see consumers that may not be tied to an independent living center or an aging agency, but they go and visit this agency because of the ethnic population or faith-based. And so we wanted to target those agencies, also the Council on Aging, and provide them with educational materials. We're using the STEADY initiative materials from the CDC and tools. We're also distributing information through the Brain Injury Association and Mass Rehab, and we're translating the materials that we will be distributing into 9 languages. The other phase is supporting and facilitating access to information and resources on brain injury. So we've developed a position called the Traumatic Brain Injury Specialist. This is one individual that we will train beyond what everybody else will be getting about traumatic brain injury, where to get resources, strategies, and kind of be the person within an ADRC to kind of bubble up issues. And so we've created a structure that I will share with you later down the line. But this is a brand new position, and this position is complemented by a brain injury elder information and referral specialist at the Brain Injury Association, where this person is tasked to increase the resources for elders in the community that have brain injury. The other element is that we are going to be developing more support groups for elders and caregivers. We are lucky that all of our partners are willing to host support groups within their sites. So it'll make it easier for family members and caregivers to attend and make use of that resource. Lastly, when we're thinking about sustainability efforts, we are putting together a project advisory board to better inform us and guide us through the next few years and even beyond the grant. This project advisory board is made up of individuals from different levels in state government. We have a representative, a senator, we have caregivers, we have survivors, and different community providers that will be joining us and on a quarterly basis and just talking about where are we with the grant, what should we be doing more of, and so forth. And lastly, we are developing a webinar. We want to share the lessons that we're learning through this grant statewide. And we want this webinar to also be used as a refresher for those that have been trained, and also to be used as a tool for training for new staff within these community agencies. So when we talk about the brain injury screening tool, we needed to find a tool that was simple, that was simple to implement, and that it meant that if they could work within the limitations of the community staff. So we really enjoyed looking at the health tool because it was very simple. HELPS, did you hit your head? And did you go to the emergency room? Did you lose consciousness? Do you have any problems because you hit your head? And then any sicknesses associated with that. So they responded well to this, and this is a tool, as you can see, it's an existing tool. So we didn't, the Mass Rehab Commission didn't create a new tool. We just used something that was already used in the past. And one of the things that came out when talking about this tool is that the community staff, they experience the behaviors that come with the brain injury. And so it was very important for them not to only identify those consumers that have an injury that they're serving already, but also how do we support these consumers once we know they have an injury. Getting to the part about results is very simple. It's yes and no questions, and there's a protocol that we have established so that the providers can come back to the office and address any needs that they found in the field. For example, starting January 1st, 2016, we're going to have all of our trainees implement this tool. Right now, we're looking at training over 500 staff. The goal for this grant was 100, and so we found that all of our partners see this as a benefit for their consumers, and we're interested in training all of their staff. So by December, we'll finish all of our training. January, we'll be able to implement this. And what we want the staff to do is, once they do the analysis in the field, share with the consumer the findings. And if the consumer has an informal support or caregiver, to share that information with that person. We want the providers to give advice to the consumers to seek further medical evaluation because, again, they're not diagnosing a TBI in the field. They're just noticing red flags, and they want to definitely direct the consumers to seek their PCPs for further evaluation. When it comes to positive TBI screening results, we want the team to go to their nurses, their supervising nurses or supervisors, and kind of talk about what adjustments need to happen with the services due to their findings. We also want them to document their results because, again, like I said, we have the head trauma data element and the TBI cognitive data element that we will be able to generate reports through every 6 months and just see if these numbers are growing and catch any patterns. We also want to have the community providers refer the consumers to other services in the community. Call the Brain Injury Association, reach out to the Mass Rehab Commission, send an application for state services. So when talking about baseline data, I just want to give you a sense of there are about 45,000 elders right now receiving services in the community, and I'm only talking about elders that are in the home care system. Out of those 45,000 statewide, we've noticed that when we pull the data on head trauma, only 1,600 came up as having a head trauma as of June of 2015. So we're noticing that we're not capturing everybody. And out of those 1,600, only 400 of those fell within our catchment area. And again, our catchment area is made up of 83 towns. We know that they have more incidences of traumatic brain injury. So there's an assumption that there are consumers receiving services that we just don't know they have an injury. Some of the issues that came up with collecting this data is that we don't have all of the data for the independent living centers. We're still working on how to extract that. We also do not have data for our Medicaid programs, our managed care programs through MassHealth. It is estimated that over 20,000 of them are enrolled in managed care services, like a PACE program that serves consumers that are 55 and older, One Care, who's serving consumers that are between the ages of 18 and 64, and then we have the Senior Care Options program, SCOPE, that serves consumers that are 65 and over. Their database and how they collect data is becoming challenging, so we have to just figure out a way where we can analyze that a little closely. This is a support structure that we've developed for the community providers. At the top, you can see we have the project advisory board who's overlooking everything. We have the operations committee, which is made up of members of the Aging and Disability Resource Consortia from the Metro West, the Greater North Shore, and Merrimack Valley. We have staff members from BIA and members from MRC. These members support the TBI specialist, specialist that is put in place in each of the Aging and Disability Resource Consortia. And as you can see, I want you to focus in the middle, the pink or orange, however comes up in your computer. To the right of that, we have the Brain Injury Elder Information and Referral Specialist, who will be working very closely with the TBI specialist. In addition, to the left, we see that we have the Mass Rehab Commission, State Head Injury Program Regional Coordinators. We have very seasoned coordinators, and these seasoned coordinators are also supported by a consulting neurologist. And what we want to do is be able to offer them as a resource to the TBI specialist when issues come up in the community where a case manager may have a consumer that they can't quite figure out how to support this consumer. They can bubble it up to the specialist and then bubble it up to the match rehab regional coordinators and eventually to the neuropsychologist. Second to last in the bottom, the role that says information and referral, options counseling, skills trainer, case managers, and nurses. We think of those guys as the gatekeepers of services in the elder service system. These guys either are initiating services or approving any adjustments for all of the programs that fall below. And so in focusing in how we're going to operationalize this, I mean, we want to institutionalize that relationship between the ADRCs, MRC, and the BIA. So we want the TBI specialist to kind of be our ear on the ground and just keep us informed as to what patterns they're seeing, what services there aren't enough of, what are some of the challenges that staff are experiencing in the field when it comes to serving consumer elders with traumatic brain injury. So I want to thank you all for listening. The slides will be available, and the references that go along with the slides will be available through Nasha.
Thank you very much, Gabby, and to our other presenters for the wonderful information presented today. This webinar will be archived, and the link for viewing along with supporting materials will be placed on the Nasha website, which is www.nasha.org. You'll see at the bottom on that red bar of the slide, and that's the education and training red bar at the top. When you pull that down on our homepage, you will see webinars and training page where all our past webinars are also posted for viewing. Meanwhile, please consider joining us for the 26th Annual State of the States Conference in Denver, October 26th to 29th. You may obtain further information and also register at Nasha's website, listed at the bottom. This conference offers an opportunity to learn about promising practices and trends nationally and within the states on a variety of issues. Nasha is a nonprofit organization. It was created by state government employees and is comprised of staff from public and community programs and other professionals involved in service delivery, as well as individuals with brain injury and family members. These webinars are supported in part by our dues and our members who volunteer their time to make it happen. If you are not a member and are interested in joining Nasha, please contact Lorraine Wargo, our Executive Director, or go to our website. If you have requests for future webinar topics, please send your ideas and requests to us at training@nasha.org. And I believe we have like 1 minute, Maria. And do you have anything you want to pose as a question?
We have several questions, and I almost hate to get started because there are so many. What we can do is collect the questions from you, share them with our speakers, receive the answers for those, and post those answers along with the archived version of the audio and the slides for you on our website. So, Susan, that's what I would suggest we do.
Okay, sounds good. I did see a number of you who requested certificates, and I believe Maria responded that you needed to send your request to training@nasha.org, and that will be taken care of. Again, thanks to everyone. It is now 12 noon Central Time, 1 o'clock p.m. Eastern Time, and our webinar is over. Thank you.